Okay, Bismillahirrahmanirrahim. Let's start, guys. My name is Shakeel Puri. I'm the president of Association of Pakistani Physicians and Surgeons of United Kingdom. And on behalf of the association and my very hardworking team, I would like to welcome you once again for our weekly webinar, which is an educational webinar. This week, we are talking about a very sensitive subject, which is touching our hearts and affecting us all emotionally. Alhamdulillah, Apps UK's webinars have been watched all across the world, and we have had reports in the past up to 27 country medical professionals working at various levels have joined us. I would like to spare a thought to start with the people, especially in the medical profession, and the people who have suffered with COVID-19 all across the world, people who are right now on treatment and their families are suffering. So my request will be, let's spare a thought. And people who are Muslims or non-Muslims, I know a lot of people who are joining us from various different countries, from different cultures and different religions, to spare a thought for our self-humans who are being suffering with this pandemic. I would like to invite Dr. Iqbal. Dr. Muhammad Iqbal is a well-known figure here in the United Kingdom. We call him the father of charity. Dr. Iqbal is working 24 hours for humanity in different parts of the globe, regardless of the country or boundaries or any human boundaries we create within ourselves. He will talk generally about the subject we are talking today. May I pass it over to Dr. Iqbal, please?
Thank you, Mr. President, Shakeel Puri and colleagues. It's a great honor for me to be invited. I'm going to talk about communication. Now, before I start telling you about communication, let me tell you something which happened with my family. My wife went to see a doctor, a very well-known consultant in the United Kingdom, and she came back with tears. And I asked why, and she said he didn't even listen to me. He didn't even ask me a question. Now, can you imagine the impact of not listening, not asking a question, not going through the history of a patient can have the devastating effect on a patient. And so every one of you has to understand what is communication, what are its implications, and what a good communication should be. The communication is imparting or exchange of information. It's not only imparting an exchange of information, but it is also understanding of the information from people or individuals. But then again, we say that with people and individual, we don't mean only humans. It can be between humans, it can be between humans and animals, and it can be between animals and animals. So we have to understand that whenever we are communicating with someone, we are actually not only flowing the information, but we are also helping them to make this information understandable. And if we don't do this, we are failing in our duty to communicate. The communication is very important because it bridges the gap between the individuals and group through flow of information to perform the task. If you don't understand, you will assume, and assumption leads to very poor communication, and you will fail in your duty, in your task, whatever you are doing, whether in the hospital or in the non-hospital sectors. So we have to understand what are the good attributes of communication. One is, in any communication, you have to show the respect to the other. If you don't show the respect, the person is unlikely to listen to you and to communicate further with you. In your communication should be friendly. Having said that, it's very difficult to say how you write a very friendly communication on WhatsApp or in any written form. But if you follow the rules that your communication should be courteous and respectful, I'm sure it will ultimately result in a friendliness. In any communication, as I said earlier, the listening is the rapport between the person who is saying words and the person who is listening. And if you don't listen, you don't communicate properly. This is why there are 2 ears and 1 tongue. The confidence is very important, that you should be confident of communication. Some people are and some people aren't. And some people are overconfident. And I think when it becomes underconfidence and overconfidence, it leads to poor communication. But it doesn't mean that we should be having an insulting attitude to those who have this one. But we should be in a nice, polite way. We should point out to them in privacy. The privacy of communication is very important, and especially in the medical field. You can understand that patient has come with confidential information, and you want to make sure that this information should not be heard outside by anyone. For example, you should not communicate with patient in such a way that the information is heard outside. For example, a nurse talking about someone saying, oh, yes, I heard Mr. Ali's father died, and this information was heard by someone who knew Mr. Ali, somebody, Mr. Ali, and he assumed about that Mr. Ali. So you have to be very careful that that the information which you have and which you are conveying on phone, in person, or in any form has to be confidential and private. And when you see the patient, it's also important that you should close the door. You should not allow anyone to come while you are having the consultation, because interrupted and non-private consultation becomes a big problem. Emotional intelligence is very important, because not everyone will come to you with calm and composed attitude. Some will have different personalities. Some will be very difficult. Some will be very anxious, and some will be even physical at times. So you have to have the emotional intelligence about your own intelligence, as well as about the intelligence of your patient. Now, your communication should be cohesive and it should be clear. And I remember a joke that once a doctor was in love with a nurse, and he used to give her a letter every morning, and the nurse used to run to the pharmacy. Somebody asked the nurse, why are you running to the pharmacy every morning? He said, well, only the pharmacist can read the doctor's writing. So, you don't want this problem. You want to make sure that your communication is clear and it's cohesive. Now, one thing which comes to mind and which is very important, especially in my role as I am the tutor for communication and ethics and law at Manchester University, that I tell them about being open-minded. Now, open-minded is something where you have to understand that you look at all facts. You just don't look at your facts, but all facts. Now, empathy is very important. Empathy is like in somebody's shoes. Think of the person, how that person is feeling before you think for yourself. Now, if you don't think about empathy, you are going to lose the communication game. Body language is very important. Professor Albert Merban used to say that 93% communication take place without any uttering of the word. For example, your mom saying, and it communicates very well with you. Your mom saying, acha. Now she has said one word and she is communicating everything with you. Now, whenever you are communicating, make sure that you are not staring at the person, you are looking at the person. And remember that social media impose a very difficult job, because people will leave the group. The reason is this, that we are just relying on the written words. We are not looking at the emotion. We are not looking at the non-verbal communication, face reading, lip reading, gesture. Same thing happens. You have to be very careful when you communicate with somebody. You don't communicate negatively about religion. You don't communicate negatively about somebody with learning disability, about the nature of the jokes. It is sometimes good to say sorry. There's no harm in saying sorry. Now, with this, I'll I will ask Dr. Irfan to take over and ask the next speaker to give you the information about communication. Thank you very much for listening to me.
I think it's Mr. President who's taking over.
Yeah. Thank you very much, Iqbal bhai. Such eloquent words about communication. Just to add everything, Iqbal bhai is one of the most, I would say, respected and experienced of all of the international faculty we have today. So we are very thankful for you explaining this very well and giving personal example, which always is very close to everybody's heart. I must add one sentence to this, that what I have learned is 85% or above communication is non-verbal. So it's the way we come across to our patients and to their families, their workers. And this is how the future plan of how to treat or how to deal with the patient when nothing is working come across. Without further ado, I will request my next speaker, a colleague from Middlesbrough. He's a consultant respiratory practitioner in Middlesbrough Hospital, Dr. Rehan Mustafa, who will do a brief presentation, and he will be talking about medical ethics. Over to Dr. Rehan. Thank you. Okay. We can see you sharing your screen now. Please go ahead.
Assalamu alaikum, and I'm very grateful to the Association of Pakistani Physicians and Surgeons to give me this opportunity to speak on this platform. So yesterday when I was asked to give a presentation, the topic given to me was to talk about ethics, particularly in view of the current COVID-19 pandemic, because obviously ethics and communications is at the epicenter of all the care which we provide to our patients. And certainly there have been some unpalatable circumstances, not just in Pakistan, but in UK as well. So we thought it was important to discuss this issue and how and when ethical principles have to be applied when making treatment decisions. So I must admit that this is a very extensive topic, and I'm going to stick to the basics and try and impart some working knowledge so that at the end of my brief talk, whoever is listening to this presentation has got a basic working knowledge about medical ethics and how they are important in our day-to-day practice. So the reason or the objectives of this presentation will be, why do we bother about medical ethics? What are the cardinal principles which you can employ in making day-to-day treatment decisions? Why are timely discussions of essence when making treatment decisions? And then briefly, we'll talk about limitations of care, limitations of treatment, and when and how the do not attempt resuscitation disorders, decisions, it should say, become applicable. I'm not going to touch upon advanced care planning or end-of-life decisions because that perhaps is not within the remit. And so starting with why ethical issues are relevant in day-to-day practice, because often there can be a conflict between health professionals and family members about the care which is received or is being planned for the patients, particularly in patients who are critically unwell and those when in circumstances are approaching near the end of life. So I've just put two things on this slide, which is time, and empathy. So as I alluded to in my previous slide, that timing of these discussions is very, very important. So in an ideal circumstance, the timing of the ethical discussions or important decisions which have to be made about the management and limits of care of a patient have to be done when patients are able to contribute to such discussions. So ideally, they should happen at the admission. So for example, in my hospital, when any patient comes to my ward, they are admitted onto the ward, we make a plan of what the limitations of care would be. When I say limitations of care, it means, are they going to have ward-based ceiling of care? Are we going to escalate their management to high dependency unit? Are we going to send them to the ICU for mechanical ventilation? And not every patient will be suitable for HDU or ITU, and we'll briefly look into the different aspects which help us in deciding which patients should have escalation of care and others which shouldn't. Again, when the other thing is time. When I talk about communication skills and ethical scenarios, particularly when I'm coaching other trainees for PACES exams, I tell them that time is of essence. So you cannot go into a discussion thinking, oh, I have to rush after this and do something else. So you have to isolate yourself, both physically and mentally, and you should be fully attentive to the patients or their relatives and forget about everything else. And whenever I go into such discussions, although sometimes these discussions may just simply take 10, 15 minutes, but I'm prepared to spend at least 45 to 60 minutes when I end up because sometimes you can end up spending that much time when you're discussing difficult and sensitive issues. And finally, as my learned colleague, Dr. Iqbal already alluded to, empathy. Empathy is putting yourself in someone else's shoes. Now, yesterday we were briefly discussing about, sometime that in certain situations, and on social media as well, and on the news, we have heard that doctors have retaliated, unfortunately, in a not so very palatable manner to the relatives and to the patients, particularly when there have been some clashes with regards to their management, or if the patients and relatives have not been happy with the care with which has been provided. So what we have to remember is not under any circumstances should doctors lose their cool. We have to keep a level head, because what we have to remember is that when patients and their families are in hospital and they are depending upon our help, they are in a very vulnerable situation. And we have to put ourselves in their shoes and think what the situation is and how would we feel if we were in their situation. And if we remember this, then life becomes a lot easier, and we can, it becomes easier to not respond in a provocative manner to situations where we would usually lose our cool. So, as I said in the beginning, that timely discussion is very important. Why are they important? Why are discussions important? Because it is important to explore what the values are, what the preferences are, what the goals of treatment are, what patients are expecting from the care which we are delivering them. And when we know what the preferences are and what the goals are, then the treatment which we are going to offer to the patients can be aligned to or be tailored to the respective needs. And if there is a disagreement between the patients and the doctors, or their families and the doctors, then we have got time to address the issues rather than leave them very late. When, for example, a patient is in an extremist situation, they're very, very unwell, they're unable to contribute to the discussion, the tempers of the families are all quite high, and at that time it's difficult to get the message across. So an experienced clinician wouldn't wait till the patient has deteriorated. The job of an experienced clinician is to identify which patients are likely to deteriorate, to assess when the patient is deteriorating, and then have a timely discussion about limits of care and about the management plan of patients. So under ideal circumstances, doctors should speak to the patients and with the relatives if they are available. But if the patient is, for example, very unwell, they are not conscious, or they don't have the capacity, for example, some elderly patients might have dementia. In those circumstances, the doctors have to obviously speak to the relatives or someone who is a next of kin or can speak on behalf of the patients. And as I alluded to before, it is important and it is essential to remember that family members may be in various stages of grief. And there are some family members who are more amenable to discussions, particularly when they are of a sensitive, let's say, sensitive. They're more amenable to discussing sensitive issues than others. So often, one of the problems, if I remember from my very initial days, is that it is best if you are dealing with a very large group of family members to ask them if they would, nominate a couple of family members who would want to join the discussion, rather than inviting the whole of the family, which can be often quite daunting and can become very difficult as well. So try and ask them if they would nominate a couple of family members who are the important decision makers, and have a discussion with them. So when we talk about ethics, we talk about the four ethical principles. And what it means is the first one, or the one which is talked about, is patient autonomy. What it means is ensuring that the informed patient's right to participate in a medical decision when we are discussing their management with them. So it is considered to be the centerpiece of medical ethics. So for example, it is not up to us to decide without the understanding of the patient how we are going to treat them. As doctors, we don't have the given right to make a decision without involving the patient. So this is, if we remember this basic principle, and this brings us back to the incidents which Dr. Iqbal was mentioning, that his wife attended attended to see a doctor, and the history wasn't taken properly, the management wasn't discussed properly. So that is at the core of problems. If you involve the patients at the right time, you tell them this is the problem, these are the options, and which one would you prefer, that would prevent any negative issues at a later time, at a later date. However, this does not mean that the patient has the right to demand interventions which are not medically indicated. To give you an example, if let's say we have a patient who has got disseminated malignancy, okay, and we all know that patients with disseminated malignancy shouldn't be having surgery. But if the patient comes in and says, I want surgery, come what may, and I want you to operate on me because I want you to cure me, then we shouldn't be giving in to the temptation to agree to what the patient is demanding. But obviously it's our job to sit them down, have a reasonable conversation with them, treat about the limitations of care, treat about the ground reality, and then get to a common ground for them to agree to an appropriate management plan. Also, different patients make different decisions. Now, what might be relevant for someone, or what might be okay for a patient, might not be agreeable for a different for someone else. And that too depends on their personal preferences, their goals in life, and their social circumstances. And so we have to bear in mind that when I talk about these things, I usually say that we have to adapt to the situation. And for example, when a player who is playing golf, he cannot use the same golf club for every different shot which they have to take. So we have to adapt to the situation. We have to adapt to the different patients. So the next principle is beneficence. So the principle of beneficence mandates that clinicians act in the best interest of patients. Now, if patients are unable to contribute to those decisions, then we have to make those decisions on their behalf, but then we have to involve their family members. So what it means is that do no harm to patients. And whatever we do for patients is to try and help them. So determining the best interest. So this is particularly relevant when patients are unable to contribute to the discussions. And the criteria which we often use in determining the best interest of the patients is, if we are going to offer any particular treatment, how is it going to impact their quality of life? At what and different is the management which we are offering, is it relevant to the stage of illness? And for example, to elaborate on this, so someone who has, because I'm a respiratory physician, so I'm going to give you a common example. Someone who's got end-stage pulmonary fibrosis, for example, or very advanced pulmonary fibrosis, and they come to you with a pneumonia or a lower respiratory tract infection. You are going to, there is not going to be much to gain if we are going to step their treatment up to the high dependency unit, or the invasive, or send them to the intensive care unit. Their interests would be best served by making sure that we are giving them optimal medical management. For example, we'll give them the antibiotics, we'll give them steroids, we'll give them supplemental oxygen. If need be, we'll give them non-invasive ventilation. But the care for them will be sealed at ward-based level. And this is something which has to be discussed with them, and the futility of stepping the treatment up to or management up to high dependency unit or intensive care unit has to be discussed with the family in a good time. Also, for example, burden versus benefit of intervention has to be kept in mind. So we shouldn't be giving anyone some treatment which is going to make their life worse than if they were not to have treatment. And we will come across a couple of examples towards the end of the presentation. Again, when we're offering anyone some treatment, we need to make sure that the patients, before they accept the management, they are aware of how long the recovery time is going to be, what potential side effects are there, and how long will they have to stay in hospital, what their life is going to be like after they have received the treatment. And again, one of the more important...
Dr. Rehan, we're running out of time, so
Okay.
Halfway now. Yeah, just briefly.
Okay.
Yeah. Thank you. Thank you.
So finally, as I discussed before, the final principle is non-maleficence, so do no harm. Again, what we have to remember is that the treatment should be available to everyone. It doesn't matter whether someone is rich or poor, or whether someone is young or old. The treatment has to be just and equitable. And we have to make sure that if their patients do have any misconceptions, for example, if they think that the treatment is denied because of any particular reason, because they are not particularly wealthy, we have to make sure that we allay any such misconceptions and explore any concerns, any anxiety or any apprehension which they might have at an earlier stage. So just quickly running through a couple of scenarios. For example, if somebody comes and they have got ischemic heart disease, and you have to decide whether we are going to give them bypass surgery or whether we are going to manage them medically. For example, patients who are otherwise fit and well and they don't have any other health issues and otherwise in good nick, we can operate on them. Other patients who are elderly, frail, have got multitude of health problems, and there's a high risk of them dying during surgery, we have to limit the management to giving them the optimal medical care with tablets and with sublingual sprays and etc. Similarly, if someone is coming in, when we are deciding about cancer care, we have to determine, are they going to survive surgery? They're not going to die on table, or they're not going to end up in the intensive care unit after surgery and not come off the ventilator. If they're very frail, they've got multitude of health issues, then we go for radiotherapy. So again, we are applying the principles of do no harm and make a decision in the best interest. Similarly, when we have a patient who has got incurable disease, whether we give them chemotherapy will depend on whether their body is strong enough to cope with the stresses of chemotherapy. If they are not strong enough, then sometimes the best thing to do is to do as less as possible. And that's what that's the phrase I use for my patients. Sometimes the best thing is to do nothing. And we concentrate on palliation rather than putting them to active treatment. So briefly talking about cardiopulmonary resuscitation and limits of care, again, patients who are elderly, frail, have got poor performance status, have got multitude of health issues, we need to make a decision in advance that these patients should not be put to the ventilator. And I think this is one of the things I need to stress on during my presentation today, because I've had a number of relatives in Pakistan, and sometimes you see this in UK as well, that patients are sent to the intensive care unit when perhaps that's not the best decision. So for example, I have had family members who have been offered offered ventilation or offered mechanical ventilation when they had incurable cancer, which I think is not a reasonable thing to do. Because if the cancer is incurable, why are we putting them on the ventilator? What are we trying to achieve at the end of the day? And this is something which we have to discuss with the family members and the patients well in advance. And so the reason why I've put up, there are only a couple of slides left. The reason why I've put this slide up is, and I've highlighted certain things for people who are seeing this presentation to see that when we are making such decisions, when somebody is not suitable for CPR, we have to make a list of the reasons why we are making that decision. Why I've written capacity is because it's important that patients contribute to this discussion. And why I've highlighted best for interest is if patients are unable to contribute to that discussion, then the family members are involved. There's a team discussion. And similarly, when we are deciding about steps of treatment, we should adopt the principle. I'm not entirely sure how many hospitals in Pakistan do this, but I've put this up on the screen for everybody to see who is watching me today, that these are the things we should be focusing on and considering when patients are admitted into the hospital. This should be done on day one, not, and we shouldn't be waiting till the patient is very, very unwell and we are in a desperate situation. So to summarize everything, the discussions should be timely. We need to involve the patients and their family members. We need to respect their autonomy. We need to make sure that we are just in making treatment decisions. We do no harm and try and give the best possible treatment tailored to the individual needs. We should avoid disagreements. And if we are empathic, we will avoid disagreements. And finally, as I said before, we have to adapt to the situation because different patients will make different decisions and we have to respect their decision at the end of the day. If a patient decides, I don't want any treatment, it's their right and we should respect that. So I will just leave this slide on the screen while if anybody wants to ask me any questions, because I think this summarizes the model which we can adapt for our on how to approach the difficult scenarios and how to make important ethical decisions.
Thank you very much, Rehan bhai. Thank you for explaining so well. I think time is running out, and we have lined up very, question and answer. I think we should leave it to the end. Without further ado, I would like to invite Dr. Nadeem Tehami, a very famous, energetic, and a unique doctor in the world who's always contributing, providing education, training, practical training. I haven't seen 1 week in the whole year when he's not providing some sort of training or educational event somewhere in the world. Over to you, Dr. Tehami. Thank you. Okay, I think
we unmute him. Yeah.
Dr. Tehami, if you can hear me.
Assalamu alaikum, everybody.
Walaikum assalam. We can hear you very well now. Welcome. And over to you now, and you're in control.
Thank you for giving me the opportunity. I am aware of the time limitations here, so I'll try to be as quick as possible.
Thank you.
Before I start, I know it's a very sensitive subject that we are discussing today. At the same time, I would like to begin by saluting all frontline soldiers, both Shaheeds and Ghazis. And I have to pay an utmost respect to the work they have done and the work they're doing. So I have about 10 to 12 minutes to talk about patient care. It is an extensive subject to talk about, and I do not believe that anyone in the world can really do justice to this topic in 12 minutes. My heart beats with the surgeons across the world managing COVID patients, but I assume my role in the webinar today is to act as a patient's advocate. Therefore, my remit today is to talk about patient's perspective, medico-legal aspect, without directly talking about the law in Pakistan. I would also then like to share my understanding of emotional intelligence, as I've learned from learned colleagues like Dr. Iqbal. So with COVID, everything has changed. The society norms have changed, but we as physicians have to appreciate that society also appreciate the work that frontline soldiers, doctors, nurses, and paramedics are doing and have done so. We were expecting, or we were told about the cytokine storm with COVID-19 infections. However, what we have seen is a storm of the information. So we find ourselves in a state of cognitive overload. So can I help? I'm not entirely sure. My job is to facilitate the objectives set out by the organizers, but all I can do is to make my worthy colleagues think. Now, we use Johari window for training purposes, and the key aspect that we want to highlight is this blind spot. We can reduce this by self-disclosure and the feedback. And if I just switch the role from doctor to the patient, and this is an aspect which I focus when I'm teaching junior doctors about communication with the patient. I was going to narrate this story, but I'm going to limit it. I'm sure you have all come across at some stage in life where you felt your understanding was limited. I'm not going to disrespect by saying that we are blind, but if you look at the COVID-19 and different disciplines have their own interpretation based on the available data. And we know that is limited to a certain extent. We're all trying our best to learn as the time has passed. It's a very busy slide, but if you look at the red boxes, unfortunately, Pakistan name comes up. And it's not going to be a surprise to all of you, but what the Imperial College London have shown that we are unfortunately in Pakistan approaching the peak of pandemic, and they predict it's going to be in the first week of August. I'm not going to talk the management of COVID-19, but I think we know that Corona is going to be with us for at least good few months, if not years. We all know about practice of hand washing and social distancing. We have to think about upgrading our public health infrastructure, but it comes at a cost. We haven't fixed things like virus testing. We cannot really count on herd immunity to keep us all healthy. However, we should try our best to keep our immunity as best as we could, and that is obviously by ensuring good nutrition. People ask me about things like vitamin C and vitamin D, which certainly helps to boost our immunity, and I therefore do not discourage. However, we have to be guided by the evidence available. We know that there are more symptoms than expected, and we all know that we really cannot count on the warm weather. So if there's anything that I want our listeners to take away is the NIHR information resource, which tells you about simple things that you can do, especially those who are suffering from COVID, some breathing exercise which could really improve their ventilation and perfusion. So summary from here is that do not let experience trump evidence. What advice patients would give? Obviously, you know when they come in, they're scared. They come in because they have faith in our abilities, and our approach is what determines the confidence they have on our abilities. So I'll just skip past all this very quickly because I'm sure you understand what patients is going through their head. So it's important to keep them posted, as Dr. Iqbal earlier alluded. So what is a quality care for every patient? Now, important thing is that it has to be patient-centered. That is, providing a care that is respectful and responsive to their individual needs. Safety obviously comes first, and that safety is our safety first. So I'm sure those who've done courses like advanced life course, sport course, the first thing you ask is, am I safe to approach? So your safety and then the patient's safety, that is the key. And it's a word you will hear all time, all along your career. So avoiding injuries to your patients from the care that is intended to help them. It has to be effective, i.e. providing services based on available scientific knowledge and best practices. Reducing wait times to delay, for which sometimes could lead to the harmful delays, has to be efficient. Avoiding waste, including waste of equipment and supplies, has to be equitable in order to get it to what we call as a patient-centered approach. Now, I guess we have a very limited time here, and I wish I had, then I would have gone into the details of these things. But what probably one message is that not all wrong acts are negligent. It's the perception that your patients have, which is what determines your success. So it's best to be on the right side of the law wherever you are practicing. What lessons we have learned is the most documentation, no matter how good you think you are doing is inadequate. You make sure you all keep all parties informed. Do not exceed your competence. And if you come across difficult cases, discuss it with colleagues. You've got social medias, you've got other channels available, and document. And as it says, it's the simple cases which goes wrong, not the difficult ones. And then lastly, I was going to talk about the emotional intelligence, which Dr. Iqbal have already talked about. But that's emotional exhaustion, which then impact on the patient care. Therefore, there are certain domains that you have to sort of, when you're reflecting on your practice, that you have to sort of over the period of time develop. Maybe on another talk, I will try to go through these one by one, but it's the message here is, or my understanding of working in UK for the last 17 years is the difference that we have in this part of the world and in some underdeveloped parts of the world is the emotional intelligence. Majority of healthcare workers in this part of the world, in my opinion, have a better emotional intelligence than our part of the world, which is why we at times find it difficult to deal with the situations like you've all come across in the social medias and print medias recently. So what are the strategies? Collaborate. Organization, you've got a fantastic organizations, Young Doctors Association, to support you. Reflect on your practice. Take advantage of the difficult times. There isn't any disaster, there are only opportunities. Complaints, if you come across, use them as to your advantage to validate good practice. And the bottom line is not the only line. So in summary, your patients need your patient. Lastly, I'll finish off by this picture that I took when I was in Jerusalem. This was on the side of Palestinian, and obviously the other sides were the occupants. And what it says, when McDonald is on the other side of the wall of your outdoor prison, you improvise, you adapt, and you overcome. Thank you very much, Mr. Chairman.
Thank you, Dr. Tehami. Very well explained. I must tell all the audience that we have now well above 4,000 people watching this very interesting webinar all across the world. And I must tell you, this is going to get even more and more interesting. APPS UK is one of the largest and the longest established organization of medical professionals in the United Kingdom. And we are creating an international audience and an international platform for people to learn all across the UK and around the world. And I noticed my colleagues who've done the presentation, they were in particularly today talking to the audience and the young doctors in training in Pakistan particularly. Which brings me to my next speaker, who is an elected president of the Young Doctors Association in Punjab. I would like Dr. Salman Haseeb to come on this international forum and do a presentation with regards to the doctor's prospect. Dr. Haseeb, can you hear us?
Yes, sure. I can hear you.
Assalamu alaikum. Over to you, please.
The previous speaker was saying something about Young Doctors Association. I could not hear him. Can he repeat what he was?
Well, Dr. Tehami mentioned that... Dr. Tehami, are you there?
Dr. Nadeem was saying...
Yes, I am.
Yes.
I think
So,
Haseeb wants to
I was trying to make a point that in order to be able to have an effective emotional intelligence, collaboration, reflection, especially with the organizations like Young Doctors Association could help enormously.
Okay, fine. Thank you, sir. Well, we have been trying to do so since the pandemic has hit Pakistan, and the things in Pakistan is not like in many developed. We have much more challenges to face than in other part of the world like UK and US. The last day, as I was discussing with Dr. Ali Raza and Dr. Affan, see, we are facing the lack of human resource. We are facing the lack of bed capacities for the patients. We are lacking the effective awareness program for the masses, and we are lacking the health budget, the finances. So actually, and also the masses in Pakistan are not literate as compared to the world because of the lack of the awareness program or the literacy rate. So all these problems actually sum up, and you see the healthcare system is not delivering. And I confess this fact: we are not able to perform in this pandemic as we could have done if we have been given with the facilities. So let me tell the many problems we are facing here. Number one is the attitude of the government and the resources given by the government. I'm not here to condemn or to criticize the action. Yet again, this is very important fact here in Pakistan. You see, already we were running short of the facilities for the patients, for the doctors. But this pandemic has added up to the problems faced by the medics in the Pakistan. So, number one, we at the moment see in today in Lahore, we are all the hospitals are filled up. Then we are not taking the new patients. There are 300 beds fixed in Mayo Hospital, 100 beds in services. I'm just giving an example. And all the beds in Lahore today are filled up. Late at 6 p.m. just an hour ago, I was in the ICU and I was shifting one of the young doctor to the ICU, and I was not able to get a bed for a doctor. He's Nakash Mazhar. You must have seen in on social media that he's not maintaining his saturation, and his saturation is below 90. So I was there to arrange a bed for him, and it took me 2 or 3 hours to arrange a bed for a health. Agree that many of the people in Pakistan are not happy with the healthcare providers. They are not happy with the hospitals and the administration of the hospitals. There are many certain reasons for this fact. Number one, lack of effective awareness program. The government could not run the awareness program based on the scientific. One minister was saying the story one way and the other was saying other way around. Similarly, even about Corona, though he was trying to keep calm the masses and he was trying to keep the chaos low, but yet it made a worse impact on the awareness programs. The masses of the Pakistan are not ready to accept Corona. First, they were not ready to accept this fact that the Corona is reality. Now they are not ready to accept the fact that the hospital staff and the hospital administration and the human resource of the hospital is trying to save their lives. Even people think that doctors and the health professionals are killing the patients, and they are naming every second patient as
I think we're having some difficult connection, Dr. Z. Okay.
It might be Salman, you turn your video off.
trying to hide their negligence behind their claims. I do. I was listening to. I do agree, and yes as well. But here in Pakistan, we change and a change. In fact, can you hear me, please?
Will
Dr. Nadeem, your connection is dropping and your voice is breaking. And we can see the passion and the emotional stress you are going through with colleagues. And we really appreciate that you are talking from the heart. And the whole idea of creating an opportunity like today is so we can work together and learn from each other and perhaps provide a certain improvement in the care to not only to the patients but also support to the medical professionals we're working with. Can you hear us well now?
Yes, yes, I can hear. I can hear you.
Yes, please do continue. Thank you.
Well, I do agree with the fact, and we as the organization, we want to work in this pandemic. We want to be the frontliners, as been announced by the government and as the media is calling us the frontliner. We do know that in this war, the white coat, the health professionals are the frontline warriors. But at the same time, we want the government, we want the public to understand here in Pakistan the problems of the health professionals, and they really need to enhance and to boost the morale of the health professionals in Pakistan. In Pakistan, the health professionals are going through the huge mental stress. You see, at this moment, more than 40% of the health professionals have test positive for corona. More than 40% of the health professionals have quarantined themselves. And what the health professionals think, and what they think the reason behind this fact is the statements of the minister and the response of the government. You know, earlier the government have been saying that every health professional do not need PPE. They were saying only the people who are working inside corona what they need PPE, while the doctors and the health professionals who are working in emergencies and the filter clinics, they do not need PPE. And the results are here. More than 40% of the health professionals and families of more than 50% of the health professionals are suffering from corona. This is not like a vague claim. This is what based on the smart sampling. They call it a smart sampling. You must have seen they test a particular fraction and they call it smart sampling. So according to their own, the government's smart sampling, more than 40% of the health professionals are suffering from corona, and there is a huge lack of health professionals here in Pakistan. So I really appreciate your effort, but you know, things can't be made better without a good initiative by the government and initiative from the very higher ups, including the PM. And here there is a apex committee where even the army sits and the judiciary is a part of the here apex committee. They need to be collaborated program against corona. Message we need to have a.
Thank you. I think Dr. Sonan, you are breaking again. Thank you very much. I think we get the gist of it, that you would like the message to be sent from the top, trickle down all the way to the bases and the frontliners, so we can help them. And this is why Association of Pakistani Physicians and Surgeons have put forward their hand, so we can help you with guidance and also with training and take you from there. We will come back to you, and when we come to the question and answer sessions, hopefully if we have time. This brings me to my next speaker of the day, a very well-known oncologist, Dr. Syed Ali Raza, who's also provided a lot of services with regards to the educational side of medical profession in Pakistan. He is very kindly going to talk to us in a little while. I'll pass you over to Ali Bhai. Can you share? Yes, we can see your screen.
Okay, thank you very much for giving me this opportunity, and thank you very much for the apps UK, that we are having a feeling that we have a organization with us who is going to take care of our doctors and our patients to their best of efforts. First of all, for my doctors who are listening to me, well, for me, this pandemic corona is actually an opportunity for us doctors to prove that we are the best. We are the actual cream of the nation. This is our challenge and we are ready to fight. We do understand that there are so much problems in the system. There are so many problems with the public. There are so many issues with the finances and health infrastructure. But we have to fulfill our responsibility, because this is once a life chance for us to perform in this way. You know, the wars are fighting by the emotions and by the ambitions, even without the resources.
Just Dr. Tehami, Dr. Ali. Okay, I think this is the problem. You've gone on mute. Sorry to the listeners. We have people joining us from different continents. And Dr. Ali Raza is actually sitting in Pakistan. And when there is a live event, as we saw with the previous speaker, Dr. Salman Hasib, he's also in Pakistan. Sometimes the internet connection goes up and down. I think Dr. Ali Raza is back with us. Would you like to continue, Doctor?
Okay, so I will be talking about the breaking bad news, which is actually more important than how to break the bad news in a pandemic where the people are already fearful. They have already lost the trust. They are fearful to die. There are so many conspiracy theories. And we have to see that how we can break this bad news. Unfortunately, COVID-19 is a bad news for the patients and their families. And I will tell here that how in this situation, following the basic medical ethics and then adjusting and merging them with the local and South Asian norms, how we can deliver a bad news in the best way. So what is the complexity actually in South Asia? We have to respond to patients' emotional reactions. We have to deal with the stress created by the patient's expectations for cure and patient's fear. And how we can do this actually. First, we have to understand that patients are emotional. They are fearful. They have some patients have high expectation because they are told that 80% of the time this COVID is only a flu. But on the other side, there are other patients who think that having COVID means death. So we have to understand that patients are emotional and we have to acknowledge that thing, and then we have to show the empathy. The second thing is the involvement of multiple family members in our setups. With every patient, there are a number of attendants who come, and everyone want to ask the same questions again and again. And due to the time constraints, we are unable to answer each of them. So what we need to do is actually, we have to ask the patient or the family to choose one member, and we have to sit with them and can make him a leader. We have to give this responsibility to him. And then we will ask him that I will communicate only with you and you communicate with the family. This can sort out the issue of multiple family members. And then dilemma of how to give hope when the situation is bleak. This is something really important. We know that many patients get worsened and the attendants don't become panic. So like every patient going on ventilator, we know that 80 to 90% of the patients may die who go to ventilator even in the best setups. But we have to tell them that still there are 10 to 20% chance that your patient may survive, and we are going to do our best for that 10 to 20%. Do remember, if this all communication goes wrong, then patient can develop a misunderstanding about the prognosis of his illness and the purpose of care. Like, as Salman Hasib portrayed, that initially the government presented an idea that it is just a simple flu. So people became careless. And now as the mortality is increasing, now the people are more fearful. So we have to be truthful that 80% of the time it is just a flu, and 15% time patient need hospitalization, and 5% patients get critical, and 2% may die due to it. So we should know this explanation to the patient. So our aim in every communication should be, we should be honest with the patient, but we should not destroy the hope. And if we follow this principle, our every talk, every word will hit in just the heart of the patient and his family. But here, the COVID is a different thing. We have some communication barriers. Doctors are wearing PPE. They are unable to maintain eye contact. The families are unable to sit by bedside of the patient. So how we should understand that there are communication barriers. Doctors are not examining the patients so frequently as they in their routine. So it is advised that still we have to ensure that the communication should be maintained. And the best way to communicate is by the telemedicine, by making a phone call to the attendant yourself twice a day, after the morning round, after the evening round. Do keep on updating the attendants and the families about the situation. you know, we heard a lot that our patient came to the hospital and he was fine, he was walking, and after few hours, we were told that he died, unfortunately. So these were the hours where there was a change of the events, and in every change of the event, it's doctor's responsibility to call the family and to tell the family that the events are changing, and so that they be prepared about this. So what are the principles of breaking bad news and good communication skills? Do remember the first thing that totally ignored in countries like South Asia and countries like Pakistan, that we don't make a setting of the interview. First principle is always do a mental rehearsal. You know, just like if you want to propose a girl, you think 100 times that what you are going to say to her. So just same to the family of a critical patient, you should rehearse in mind that what should be your exact wording, that true information is conveyed without hurting their feelings. And then, as I told earlier, we have to involve other family members as well. They want to know, because in Pakistan, the communication is more attendance-based rather than patients-based. And we have to modify the basic principle of communication to attendant-based as well. Third thing is that, another thing is that usually we are doing the communication in the corridors or on the counters. No, this is not the way. Even if you have 5 minutes, just sit with the patient, and then it will calm the situation, and then talk with the patient. And fourth is connect with the patient, as we know, maintaining the eye contact, and manage time constraints. Do tell them that you have only 5 minutes, and don't use mobile. But I have seen that our doctors are talking with the patient's attendants, and they are messaging or texting or using the mobile in one way or other. That's how the patient or the attendant feel that he's being neglected, or our doctor is not very much concerned. So we have to take care of this thing. Then we have to assess the patient's perception. You know, due to this social media, due to the panic, due to the conspiracy theories, the patient perception has really changed. So you have to understand that what is the patient perception about his illness, and is he feeling that nothing will happen to him? Then you have to be truthful that no, you are fine, but something can happen to him, to you in future in bad way as well. Or if a patient is really very much worried, then again you have to calm down him. So you have to understand what is the patient perception and what he's expecting from you. There is not one answer for every patient, and you have to ask them to ask any questions right before you start, because if you will be knowing that what are the concerns of the patient, you will not be able to deliver the correct information to them, and you will not be able to develop a rapport with them. By this time, do remember that patient is prepared now. Patient, you have developed a rapport with the patient, you know patient perception, your patient has asked you some questions. Now it's the time to deliver the right information to the patient. But do remember, always give warning shots. Sometimes what happens is a patient is expired, and we just go directly to him and tell him that your mother or your father is expired. And they are in a denial, anger, and they just react in the same way as we have conveyed the information without giving them any time to absorb or digest. So we have to prepare the attendants or the patients before telling them a bad news. So always give warning shots, and then we have to address the patient's emotions. Do remember, patient emotional reactions may vary from silence to disbelief, crying, denial, or anger, and that is what we are seeing in Pakistani hospitals where anger is predominating. Do remember that these are expected emotions. This is the way the human body and human brain and human heart reacts to such situations. So you have to acknowledge, and then you have to address. And how you can address is by identifying the reason for that emotion. Is the attendant is feeling that he was not told then adequately about the patient condition, or he had some bad experience, or there's a conspiracy theory going on him? If you identify the reason, believe me, then you will be able to address the reason in a firm manner. And finally, this is a very important thing, that do give them all treatment options. The problem is that there is only one-way communication. The doctors tell to the patient that you have to isolate, or you have to admit, or you have to go to the ventilator. No, there should be a shared. Tell them that this is a situation, and in this situation, we think that you should be only self-isolate at home. But what is your idea about it? Then if you will share the responsibility of this decision-making with them, believe me, if your treatment fails, still, there will be no blame on you. Do involve the family, do involve the patient in shared decision-making, because it is their right. So if these are the basic principles, but you have to modify them according to the situation, according to the cultures, according to the religious norms. Even if possible, like we know that the attendants and the families and patients have lost trust on the doctors. So, and sometimes they more believe on the lab reports than the clinical findings. Then do involve them in the lab reports. Do show them our normal X-ray, and then show them the patient X-ray and tell them that these are the new changes in your X-ray. That's why your patient is critical. Do show them the normal oxygen saturation by their finger, and then show them the saturation of their patient and tell them that, see, this saturation is dropping, so that what they believe that their patient went to the hospital fine and something was done by the doctor. No, problem is only that our doctors are not communicating effectively. Even in the time constraints, in the 5 minutes, you have to be truthful, honest. You can practice all these principles, and after that, I believe that this patient and public doctor-patient relationship will really improve, and this will really motivate you people also to deliver them the best. Thank you very much.
Thank you very much, Dr. Ali Raza, for explaining so well. It's again and again coming to communication with the patient and the family, the non-verbal communication, which patients can see and feel when you're not even talking. This brings me to a very important topic, which is the social media communication. And to present that, I've got Dr. Affan Qaisar, a well-known name in the medical fraternity in, I would say, not only in Pakistan, but across the world. He is an upcoming medical journalist and a future star in the medical world. He is ambassador of APS UK in Pakistan, and I'm sure his presentation will be very enjoyable. So I'll pass it over to Dr. Affan Qaisar. Over to you, Doctor.
Thank you, Mr. Shakeel Puri Saab. You have said a lot about me, and thank you very much for your kind words. APS UK is doing great work, and I am really impressed with the way APS UK have supported PLAB to residents and the way they have responded in this COVID crisis. My topic is that how to handle social media and how medical professionals should handle social media. The dynamics are very different. They are totally different dynamics across the globe via doctors are approachable to social media. In your world, you people are not allowed in UK to be a medical journalist when you are working in some hospital setting, or you people are even not allowed to reach the confidentiality of patients, and there are lots of legal issues. But in Pakistan, the dynamics are very different. The doctors are allowed to do whatever they want on digital media, and that is why there are many things that happens across the board that are not good. As far as the approach to social media is concerned, I will talk in two different aspects. The Pakistani doctors in Pakistan do one big mistake. They are very aggressive. If Salman is listening me, they have a very aggressive approach sometimes towards social media and the social media handlers. Salman, are you listening me? YDA Punjab president, if he's here. I don't know. I think he was having net problems. So their approach towards social media is a bit aggressive. I must say that the media houses or the digital media, it should be handled with extreme delicacy when you are sitting in a setting like Pakistan, where everyone is allowed whatever they want to speak. I always say in Urdu one word, that हम बहैसियत कौम बदतमीज हैं, चाहे डॉक्टर हो और चाहे attendants हो. So we as a whole have to learn manners, and the manners comes with your grooming, and the grooming starts when your national these figures who are controlling the whole regime or whole era are concerned about your ethics, your ethical education. And your ethical education comes either with your religion, or it comes either from your parents. And when it comes to parents, the Pakistani economic crisis is so bad that you are ready to give birth to 4 or 5 children, but both of them are either working, or they are or either they belong to an uneducated class. They are not ready to give time to their kids, and from this the lacking of their ethics start. And when it comes to either from these children, we produce doctors or we produce attendants. So we produce a nation which is as a whole कि हम बहैसियत कौम बदतमीज हैं. So when two such classes interact at any way, either they interact at road, they interact on social media, they interact on in hospitals, they will fight, and they will always try to mishandle things. And when there is uneducated class in huge quantity in the society, they will believe on myths. You people sitting at UK are very relaxed, because you do not have to teach attendants that yes, the corona exists. Yes, we are not getting the dollars from the dead bodies. Yes, we are not sending your dead bodies to America, and America is sending dollars to us. And you are not to tell people that do not use this cinnamon or sana makki, that and it is not good for your coronavirus. But we have to deal these things. We even have to answer, Dr. Saab, muh kaise dhona hai? When you are sitting whole way in a tense situation and dealing people like this, you get frustrated, and in all this frustration you mishandle many things, including social media. So my advice to Pakistani doctors is that you should be either you shouldn't join social media, and if you want to use social media, then you should be very polite, very humble, and very authentic when conveying any information, and do not convert your information to disinformation. Because if you will pass, if Affan Qaisar will give a statement that Sana Makki is good, then you are destroying the whole scenario. You are building a whole narrative of something bad to people. So we have to be very limited in that. Salman was talking about limited resources of PPE, N95 and all the things in Pakistan. These are scenarios which exist there, but calming them again and again on digital media again builds a narrative which is not good, because it will bring a distrust between you and your patients, that you people are after things, and you people are not after treating us, or you people are not concerned with us. So these things are very important. For social media, we should be humble, we should be benign, and we should be based on, we should pass information which is authentic, and we should always not break the patient's confidentiality. And for UK, I have never visited UK. Hope President Mr. Shakeel Puri will invite me, and I will be amongst you people one day. But you people as a doctor handle social media very well, and I don't think so that I am someone who can comment on social media ethics other than Pakistan, because you people handle things much better than we Pakistani doctors practicing in Pakistan handle social media. We have to detoxify our aggression on social media, and that's the only message. Never blame a social media channel, never counter attack a channel, never ever say bad about your health authorities, and never strike your government authorities. They are striving fast, but when you try to politicize the things on digital media, you built a false narrative. This is something which is, I have spoken my heart out. If Salman would have been sitting, then this thing might be he would have interfered many times, that I am speaking a narrative which is 180 of what Young Doctors Association's narrative is. You should fight, but we have to detoxify the aggression. Thank you very much.
Thank you very much, Dr. Affan. As I said to all the viewers, this will be a very passionate, talk from Dr. Affan as usual. I think it all have to be acknowledged that two of my very learned colleagues, very senior colleagues, Dr. Abdul Hafiz and Dr. Irfan Rashid, is sitting here, and they are constantly monitoring and answering questions as we are going on social media, on Facebook, and also on this webinar going live. I had a variety of speakers with very different experiences. We don't take the credit that we are experts in teaching you, but we all have much more experience than you, the junior doctors there in Pakistan and working across the world. The message is that let's communicate better. God communicates to humanity through his prophets. We need to learn how to communicate the patients who are younger than us, patients who are older than us, people who are suffering and struggling. And I take this point of communicating when we are very tired and we are sweating and we got this all PPE and all the rest of the stresses. We are worried that we're going to go home. Are we going to take this virus with me to the family? There is a lot of stress. Now, how do we control this stress? Perhaps that's a topic for another day, but let's work together, support each other. My request to the junior doctors would be that please don't just think of the patients. They are the point of focus, but do look after you. You are also a body which needs to be calm, psychologically, mentally, and physically. Look around and help out your team. Your team is your people who are working at your level, your seniors who may be stressed because they've got a lot going on in their plates. They are heading a department. Maybe they are suffering from anxiety. Look at the nurses around you. Look at the other doctors. When you have a break, talk to them. See if they require any support and comforting words from you. Because if we are not going to be the crying shoulder for each other, who else is going to do it? May I request Dr. Abdul Hafiz, who's the CEO of Association of Pakistani Physicians and Surgeons, to say a few words, please. Over to you, Dr. Abdul Hafiz.
Thank you very much. I mean, once again, this topic has generated unbelievable interest. As you can see, I think there are 5,000-6,000 hits on our live Facebook stream at the moment. Very passionate speakers. I don't think we have done justice to the topic. Obviously, I mean, I would suggest that we actually have a part 2 at some stage in a few weeks down the line. We already have a very powerful lineup of other topics which are obviously already confirmed. What I would suggest as an Association of Pakistani Physicians and Surgeons, obviously we have come from Pakistan and we know the realities of how things work in our country. Things obviously have gone probably worse because of the pandemic and the scarce resources which are available. But obviously we are here to provide all the information, guidance, support. Communication is a very powerful tool, and many times we can actually use this tool to de-escalate things. And it does require a lot of training and practice. And I think, inshallah, we will have a lot more coming in the future months in terms of educating on the communication side, which I always feel is lacking in the Pakistani medical training. Thank you.
Thank you very much, Dr. Abdul Hafiz. My younger brother, Dr. Irfan Rashid, has been working very passionately in the back. Dr. Rashid, you want to say a few words, and if there are any questions from the panelists, I would like to welcome Dr. Salman Hasib again. We can see you, and hopefully we will hear from your contribution again. Over to you, Dr. Irfan.
Thank you very much, Mr. President. I think we answered most of the questions in presentation and individually as well, unless there are some questions on Facebook if somebody is following.
Yes, I don't think there's anything more now.
Yeah, this is a huge topic, and we are already 25 minutes over our webinar. This is one of the lengthiest webinar we have ever done. So you can imagine the importance of this webinar. And Abdul Hafiz Bhai rightly said, I don't think so we have done justice with this topic. We can discuss more and more. And inshallah, hopefully we'll have another part 2 in future. And the people who watch this webinar, they will be given certificate if they apply to the email and respond to few questions. So they can have those CPD points. The recording of this webinar will be available on www.appsuk.org website. And we already briefly mentioned we're doing another webinar on cardiology next weekend. And the weekend after, we're doing COVID-19 and surgical emergencies and point of care, or the best investigation for that. Anything else, Hafiz Bhai, you want to add about future plans?
No, it's okay. I think we are quite short of time.
I think we're going above and beyond time. Thank you very much, everybody. Dr. Salman Hasib, you got cut off because of the connection. Would you like to add a couple of sentences? Can you hear us? I think we're still having some communication issues with that part of Pakistan with Dr. Hasib. We can see him sitting there. Right, okay, that brings me to the conclusion. I'm very, very thankful, all of you who have joined us, who've spent time to prepare their contributions and their presentations. Maybe that we can work on this and build on this and amplify whatever we learn from each other. And I'm talking to the panelists and also the people who have joined us all across the world. Spread this knowledge, be there for each other, communicate in the most politest. If you want somebody to be your friend, we can't say to them, you are wrong, or you don't know anything. Perhaps we can use a better terminology. I think the word corona, that you have a corona in Pakistan, is seen as an abusive word. Perhaps we can use a little bit of a better word or a better terminology. We've learned very well from Dr. Rehan and Dr. Ali, Dr. Iqbal, Dr. Tehami, and our lovely Dr. Affan Qaisar, that it's the way you say things. You might be saying the right thing, but if you say it the wrong way, the listener might hear it the wrong. But if you say even the wrong thing in the right way, people will have something positive out of it. On that, I would like to pray for all the medical professionals who passed away around the world, and especially the younger ones who've given their lives due to whatever reason in Pakistan. That brings me particularly Dr. Salman Ali in my mind, who's recently passed away in Punjab, Lahore. There was a lady doctor in Nishtar, a nursing colleague who was 9 months pregnant, also in Pakistan. And these deaths, we need to learn how could we have avoided these deaths and make sure that we support and join our colleagues who need support and make sure that these doesn't happen again. On this, I would like to conclude today's webinar. Thank you very much, and keep us in your mind. And if you need any further support and advice, please go on our website, which is www.appsuk.org, and our email address is admin, which is ADMIN @apps.org. Thank you, and Khuda Hafiz, and thank you.
Thank you very much.